Yes, thank you. My name is Nathalie Wong-Chong. I'm a colorectal fellow from McGill University, and this is a joint venture between McGill and Florida Hospital. I have nothing to disclose. So we know that the mainstay of treatment for stage 3 colon cancer is surgical resection followed by adjuvant systemic therapy, and this has resulted in decreased rates of local regional recurrence and increased overall survival. We also know that delays in treatment of adjuvant therapy result in poor survival, and yet over 20% of patients with stage 3 colon cancer are not considered or offered adjuvant systemic therapy, and this may be due to a multitude of reasons, including to ineligibility due to patient comorbidities or poor performance status. Recovery after surgery may be prolonged, and patients may develop surgical complications postoperatively that may delay chemotherapy. Minimally invasive surgery has been shown to be superior to open surgery for short-term outcomes, resulting in decreased blood loss, fewer wound complications, earlier return to bowel function, decreased postoperative pain, and shorter length of hospital stay. So our hypothesis is that minimally invasive surgery may improve surgical recovery and reduce time to adjuvant systemic therapy after colon cancer resection, and as such may have some long-term survival benefits. And so the aim of our study was to determine the effect of MIS on the initiation of adjuvant systemic therapy and on survival in patients with stage 3 colon cancer. The National Cancer Database includes approximately 70% of all new cancer cases in the United States and collects data from 1,500 hospitals. And so we queried this database to identify patients who had a resected stage 3 colon cancer between the years of 2010 and 2014. Patients were then divided into two groups, minimally invasive surgery and open surgery. And MIS surgery included laparoscopic, robotic, and cases that were converted to open. We excluded patients who had rectal cancer, who had metastatic disease at diagnosis, who received neoadjuvant therapy, who did not undergo surgery, or who had histology other than colonic adenocarcinoma. Our main outcome measures were delayed initiation of adjuvant systemic therapy, defined as longer than 8 weeks postoperatively, and this cutoff was selected due to data suggesting poor oncologic outcomes with treatment start date above this time frame. Our other main outcome measure was 5-year overall survival. We then performed propensity score matching to minimize the selection bias given our observational study design, and then performed a multiple Cox regression analyses to identify independent predictors of 5-year overall survival, adjusting for clustering at the hospital level. So we identified 86,680 patients that met our inclusion criteria. 45% had an MIS procedure, and the remaining 55% had an open procedure. Of the MIS cases, 3% of overall cases were done robotically, and the overall conversion rate was 14.4% in MIS procedures, and this was lower for the robotic cases, 8.6% versus 15.2%. In our unmatched cohort, there were a lot of differences in terms of patient, facility, tumor, and operative characteristics. Once we did our propensity score matching and looked at our matched cohort, we identified 33,183 patients in each group, and the patients were then well matched in terms of patient and facility characteristics, as well as operative details and pathologic details. When we looked at short-term outcomes, as evidenced in the literature, there's a shorter length of hospital stay in the MIS group with a mean difference of 1.5 days. And what we found was that patients in the MIS cohort were more likely to receive adjuvant therapy and to receive adjuvant therapy in a timely fashion. They were also less likely to not receive any adjuvant therapy at all, and this difference remained after our propensity score matching. We also found that on univariate analysis, the MIS approach was associated with earlier time to less delay to adjuvant therapy. Not only did they have a less delay to adjuvant therapy, they also had a higher 5-year overall survival, and this was statistically significant. When we looked at our 5-year overall survival, we found that delayed initiation of systemic therapy beyond 8 weeks was associated with worse 5-year overall survival with a hazards ratio of 1.3. And when we looked at the effect of surgical approach and time to adjuvant therapy, we found that MIS was independently associated with improved survival with a hazard ratio of 0.8. And when we stratified according to the interval of time of systemic therapy, this association was still significant. Several limitations, including that the NCDB does not record local recurrence or development of metastatic disease, and as thus we don't have information on disease-free survival. There's also lack of granular data, so we don't know what type of chemotherapy regimen these patients received or whether or not the rates of compliance were different between groups, and this can affect survival. We also do not have information on postoperative morbidity, and we know that infectious complications can lead to promotion of metastatic disease and affect survival. And so there's possibility of residual bias of unmeasured confounders. And we also must consider that these results may not be widely generalizable to hospitals that don't participate in the NCDB, and we may have underrepresentation of certain ethnicities. In conclusion, we found that MIS surgery for stage 3 colon cancer is associated with a less delay to adjuvant therapy and improved survival. So surgeons should favor MIS approaches for the treatment of stage 3 colon cancer whenever possible. Thank you for your attention.